Good evening, everyone, and welcome to Henry Schein Dental Academy webinar. My name is Dr. Gary Severance with Henry Schein, and I'll be your moderator for the night. Tonight, as always, we're excited to welcome Dr. Heidi Kohltfarber as our speaker, as she'll provide tonight some best practices for 3D anatomy and the applications for implant treatment planning. Before we get started, a few reminders. At any point during the webinar, if you have questions, please type them into the Q&A. Not into the chat, but into the Q&A, and we'll answer them live at the end of the webinar. If it goes anything as in the past, Dr. Kohltfarber has many, many questions and is able to give great advice to any of those questions. Reminder, Henry Schein is not offering CE for viewing or attending this presentation, live or on demand. Dr. Kohltfarber, always great to listen to you and see you. Thank you for joining us tonight. It's all yours.
Thank you so much. I really appreciate it. Thank you for the honor of getting to share 3D anatomy and the applications for implant treatment planning. I am going to apologize just a little bit for the sound of my voice. I'm in California and we have a bunch of fires around us, and the smoke is not treating my sinuses very kindly today. So I'll apologize for that, and hopefully you all can stick with me and enjoy watching all of the anatomy. Rationale for a recommendation of pre-implant imaging. So as we know, we all want to take some pre-implant imaging. Why would we want to do that? Well, it's going to help us to improve our diagnosis. It allows for optimum implant selection, avoidance of surgical surprises, and becomes a basis for our guided surgery. It's also incredibly important for medical legal documentation. As I said, I am in California, and it is a very highly litigious society here. So we have seen a lot of legal cases where there's great concern if anything were to go wrong with the placement of that implant, if there is not 3D imaging beforehand to document exactly how everything looked like, that can pose a problem for us. And so we're seeing, we wouldn't say standard of care. I would say, from a radiology point, we have not used that word. But from the legal community, we're really seeing this being pushed in a similar fashion to that. And so I think that having the documentation ahead of time with the CBCT to show all of your anatomy and to show that you've properly planned things is very, very important, especially if it were to move to a medical legal arena. So I think that's a great basis for it. It's becoming more important, which is, I guess the signs of the times, isn't it? All right, so let's talk about our anatomical considerations. I love this painting. This is by Rembrandt. It's the anatomy class or anatomy lesson of Dr. Nicholas Tulip, and it was painted, I believe, in 1648. Now, one of our smart anatomy students has refashioned this and put this together for what today's anatomy class might look like with everybody in on Zoom. So I thought that was fairly clever and very apropos for today's lesson. What are our areas of anatomical concern? Maxilla and maxillary sinuses, definitely. We have all of our neurovasculature as well, so we'll talk about that. Mandibular canal and mental foramen, lingual cortical plates, and of course our submandibular gland fossa region. And of course we can have large marrow spaces, and so we'll talk about things like osteoporotic bone marrow defects and that sort of thing. So just kind of a quick overview for those of you that don't have a CBCT. This is what a Chromium CT reconstruction and views look like. This is our multiplanar reformatted views, or NPR views, as we like to say, and we will have an axial section. This is looking from above down. We have our coronal sections, which is looking from the front back. And then we have our sagittal sections down here looking from side to side. And then we often have a 3D skull view, or we can do a custom section as well. When we are looking at any of our sections, we want to remember In this particular one, the nose is down, so this is anterior, and this would be posterior. This is right and left because radiologists never know their right from their left. In fact, I already know which one of my kids is going to be a radiologist. She doesn't know her right from her left. Now, some of the software, you'll notice that the nose is up, in which case this would be anterior, this would be posterior, but your right and left still stays that way. So it's just how you've restacked all of your slices and how the settings in the software are selected. And we're looking at a coronal section. Again, remember right and left. This will be superior and inferior. Sagittal sections, we have anterior, posterior, superior, and inferior. And the same thing with our 3D skull view, anterior, posterior, superior, and inferior. When we're looking at any of our images, we always want to use a systematic approach. And I know I've talked about this before, so we'll go briefly through it. But we really want to gather all of that patient's information. You want to remember who your patient is and take them into account. You want to look at any of the existing radiographs that they might have. And then you can use that to determine if something has changed in size over time, or if there's any changes to the anatomy that you might be interested in, such as alveolar atrophy. We want to use a systematic search pattern when we're reviewing each of our CBCTs. So all of our CBCTs should be evaluated in their entirety. I know we're very interested in an implant or a couple of implants. We are very interested in just looking at one particular location, but it is important, ethically and legally speaking, to evaluate the entire scan for our patient. And we do that from going or looking at a global perspective down to a more local perspective. I look at things globally using my axial and my coronal sections, and then locally I'll use my sagittal sections. And we look for lack of symmetry. And so we'll talk about that in a little bit as well. We also want to make sure that we're using the radiographic signs. We've talked about those previously. And of course, we want to remember there's independence of imaging modality. So what does that tell us? If it looks like a cyst in 2D, it's going to look like a cyst in 3D. We're not reinventing the wheel as far as all of those radiographic signs that we've always used. And then when we're looking at our scans, if we do notice something, we want to make sure that we write it up using those radiographic signs. And then that leads us to categorize things into a particular disease category. So here's symmetry. Again, we want to examine both sides. You can always compare your right side to your left side. We can do the same things in our coronal and axial sections, which is why I use those sections to look at things globally. And then, of course, sagittal sections, I don't have another side, so I use that to look at things locally. Now, asymmetry can be an anatomic variance. So when we look at our anatomy, we're going to mention what is the anatomical variance. And then some diseases are bilateral. Okay, so here's a great little video.
The human skull is made up of 8 cranial bones that surround and protect the brain, and 14 facial bones that form the underlying structure of the face and support for the teeth. With the exception of the mandible, the bones of the skull articulate with each other through joints known as sutures. Throughout the skull, holes known as foramina serve as passageways for blood vessels and nerves. Bones on the surface of the skull encase the brain, protect sensory organs, and serve as attachment sites for the muscles of the head and neck. These bones include the occipital bone, parietal bones, temporal bones, and the frontal bone, as well as the nasal bones, the zygomatic bones, the maxilla, and the mandible. Other bones become more visible only when looking inside the skull. The sphenoid bone makes up the anterior base of the cranium. It is a butterfly-shaped bone with a central body and 2 pair of laterally projecting wings. These wings form portions of the orbit. The body of the sphenoid features a depression known as the sella turcica, which houses the pituitary gland. Located between the orbits, the ethmoid bone makes up a portion of the cranial floor and also the roof of the nasal cavity. An inferior projection, the perpendicular plate of the ethmoid bone, forms part of the nasal septum. The crista galli projects superiorly from the ethmoid bone and serves as the attachment point for the falx cerebri, a dural fold. Extending laterally from the crista galli is the cribriform plate, a perforated area through which the olfactory nerves pass. The two L-shaped palatine bones form the posterior third of the hard palate, part of the nasal cavity, and a portion of the orbit. The small, thin lacrimal bones make up the anterior portion of the medial wall of each orbit. A groove known as the lacrimal groove helps to form the nasolacrimal canal, which contains a duct that allows tears to travel to the nasal cavity. The vomer is an elongated, plow-shaped bone that forms the inferior and posterior part of the nasal septum. The internal and external skull bones articulate precisely, forming an intricate structure perfectly suited to its functions.
Okay. I just love that video. I sure wish I had that in dental school. So these are some of the anatomical features that we're going to talk about. I'm clearly not going to go back over a conventional panoramic, but these are all of the areas that we are always supposed to be reviewing, even in a conventional panoramic. And I think they're much more difficult to visualize than they are in 3D. So I think that those 2D conventional pans can be a little bit more difficult. So when we're looking at our skull and maxilla, these are some of the areas that we're going to discuss. We've separated it out. So we have skull and maxilla, and then we're going to talk about the mandible. So let's start with our maxillary sinuses. These are air-filled cavities. And we can see that when we are little, we have very, very tiny little sinuses. And as we grow and develop, these sinuses pneumatize down. That gives us the shape of the sinus. It also lowers our voice as we grow and develop. But it's very important to realize that sometimes sinuses are not symmetrical. In fact, when we like to sit and talk about symmetry, and we talked about there's certain anatomy that is not symmetrical, our sinuses are not usually symmetrical. So it is possible to have a very, very small little sinus known as a hypoplastic sinus, and that is considered to be completely normal or variation of normal. Many times we'll see there's a mucosal thickening in it, though, because the sinus drainage pathway has not developed properly. Now, the majority of people do have something going on in their sinuses, as I'm pretty sure that I do today with all of the smoke in the air. But sinuses are very important, especially if we are considering a sinus lift and bone graft. Now, if we do see a mucosal thickening within the sinus, we always want to check out the teeth. But we can see we have a periapical lesion, lost the inferior cortical border of the sinus on that side, and that mucosal thickening is odontogenic in origin. So we wouldn't want to just send that straight off to ENT. We would want to check the teeth first. However, we are very concerned about that sinus drainage pathway. So when we're looking at our sinuses, we want to look at the ostium or the opening. We want to make sure that this is nice and patent, the whole osteomeatal complex. And this is really what ENT is going to be concerned about as well. We can see our nice little ostium right here. Here's an ostium on one side, ostium on the other. It's ostia if we're talking about it in the plural sense. And so we've got a whole nice osteomeatal complex. Why is that important? Well, because it is possible if we have a mucosal thickening and we decide to come in and do a sinus lift and bone graft, it's possible to lift up that mucosal thickening and block the ostium. And we would cause an issue with the sinus on that side. In fact, the sinus can become a pathological cavity in and of itself and start to expand in size. We're going to start to see destruction and displacement of cortical borders. We do not want that to be our fault. So if we see a mucosal thickening that is in the sinus and you're planning to do a sinus lift and bone graft, I would recommend that you send that off to ENT first. It does a couple of things. Number one, it lets the patient know that they had this condition before you touched them. And so it won't be your fault. So I think very important to let them know. Number two, it allows ENT to clean out the sinus so that you have a nice, clean surgical site to work with. We can also have maxillary sinus septations. We can see that right there. Now, when we are evaluating a sinus for a sinus lift and bone graft, that's one of the things we might want to pay attention to is a sinus septation. Now, these are considered a variation of normal, fairly common to see those within the sinuses, but we do know that it could cause some issues if you're planning to do a sinus lift in that area. The membrane is going to be folded in a particular way. We wouldn't want to cause any issues with that sinus lift. So definitely something to look at. And we're talking about sinuses. Again, we know, the majority of people are going to have something in the sinus. So we can look at acute versus chronic rhinosinusitis. This is an acute sinusitis. We have a bubbly appearance within the sinus. In fact, if we look at it in all three planes, we can see little waves. And we can also see, of course, this particular one, extensive amount of bubbles, again, letting us know we have those active secretions. We can look at our cortical borders, make sure those are nice and thin and intact. So we know this is something that is an acute rhinosinusitis. Probably don't need to do anything about this for this particular patient. We usually don't send them off to ENT unless the patient has persistent sinus symptoms of longer than 2 weeks duration, unless you're going to be doing a sinus lift and bone graft on that side. Here's a chronic sinusitis. And you can see we've got thickening and sclerosis of those cortical borders. They're not nice and thin. In fact, we can compare one side to another and see that there's some difference in symmetry. What's happening is the body is laying down additional bone in response to that inflammation. It's trying to wall it off. And we also, in this particular case, have some dystrophic calcifications floating within the mucosal thickening. But this could be a sign of a fungal infection as well. And we can't tell the difference with our CBCT. So we definitely want to send this back to ENT. This patient does have an enlarged osteomeatal complex. That lets us know that they have a past history of sinus surgery. So usually our ENT friends will come in here and go ahead and enlarge this drainage pathway for us. So this is a chronic rhinosinusitis. Definitely we would refer this. When do we refer? Well, this is something that I would sit down with your local ENT, whoever you're going to be referring everything to, and ask when they'd like to see your patient. And then let them know that you do place implants, and you'll be sending them from time to time, especially if you're planning to do a sinus lift and bone graft on that particular side. But I think very important to have that conversation. There's a lot of different schools of thought among ENT as to when to treat something, just as there is in dentistry. All right, so our nasal fossa and septum. So I want to make sure we have a nice straight nasal septum. Actually, majority of people have a deviated nasal septum, and that'll decrease the airflow on that particular side. So this is actually kind of an anomaly. It's a straight nasal septum. It looks great. Of course, we can look at our cortical borders of the nasal fossa. Also look at our turbinates. Our nasal turbinates, you'll notice that occasionally we're going to see a variation in the size of those turbinates. That is completely normal. We have a normal fluid flow in our bodies throughout the day. It's a normal diurnal variation. And so if you image Mrs. Jones in the morning, you might notice that this inferior turbinate is larger than that one. If you were to image her in the afternoon, you might see just the opposite. So that's completely normal. Doesn't mean she has congestion. Our lacrimal ducts, if our nose is down in this particular software, this are maxillary sinuses. And medial and anterior to it, we have our nasolacrimal ducts. And of course, this extends from the medial aspect of the orbit down into our nasal fossa. You can see that very nicely in our sagittal sections. And of course, as you have fluid flowing down from your orbits during the day, it extends into the nasal fossa and it can cause your nose to drip. So that's why many times if you were to cry, your nose is going to drip along with it. It's all related. Right, the hard palate and floor of the nasal fossa. So we can see this very nicely. What we want to appreciate is there's a lot of topography to our hard palate. You see that right there. Here as well. We want to make sure that we realize the hard palate's not straight across. There is going to be some topography to that. Talk a little bit about our maxillary innervation because that becomes very important, especially for doing our sinus lift and bone grafts. And we're going to talk about our maxillary nerve, our V2 of trigeminal. We can see, of course, we have our V2 that extends through our pterygopalatine fossa. And as it extends through, we've got our pterygopalatine ganglion, and then it starts to give off branches. We've got a zygomatic branch. Of course, we've got our infraorbital branch, but you also have your greater and lesser palatine neurovascular canals coming down. And we do have some small little branches that extend off. This is part of our dental plexus. You're going to have the posterior superior alveolar neurovascular canals, and they're going to kind of extend forward with this dental plexus and join with our middle superior alveolar neurovascular canals and the anterior superior alveolar nerve canals. Now, we do see a lot more canals in 3D or neurovascular canals than we ever saw in 2D, so we can see these, and we do want to avoid them if possible. The anterior superior alveolar neurovascular canal, it's any neurovascular canal. It's going to be a linear radiolucency or a linear hypodensity when we're talking about it in terms of a CBCT. A linear hypodensity with nice straight corticated borders. And you'll notice it tracks through your scan. Typically, our anterior superior alveolar neurovascular canal will come down around the canine region. That's according to the anatomy books. This little guy didn't read the anatomy, and sometimes they don't. He's extending down inferiorly in the region of the lateral and anterior incisor. So we do see that. And you'll notice that this is a rather large canal. So obviously a nice neurovascular canal, nice linear hypodensity with corticated borders. It extends right down. Now, we do need to be careful with some of these. Something that is this large, it could cause issues if our implant is placed within that neurovascular canal. And so there's a size requirement when we're talking about possibility of impingement on neurovascular canals. Now, of course, radiology, we see the good, the bad, and the ugly. We do have a very wide no judgment zone, but we have seen cases where small incisal type branches, whether in the maxilla or the mandible, can cause numbness if they're impinged upon and that sort of thing. So definitely we want to avoid those neurovascular canals whenever possible. Posterior superior alveolar neurovascular canal, we can see that. We talked about how that extends along that lateral inferior aspect of the sinus. You can see him extending forward here, and you can see him right there as he extends anteriorly and anastomoses with the other dental plexus branches. We want to avoid this if possible when we're doing a sinus lift and bone graft. So something to look for if you're evaluating that sinus for your sinus augmentation. You want to measure exactly, where it is from the inferior aspect of the floor so we can try to avoid it. Now, it may not always cause, I talked a little bit about neurosensory deficits. It may not always cause neurosensory deficits, but it certainly, if we were to clip this by accident, is going to bleed quite a bit. And that's going to impinge your ability to visualize the surgical area as well. So if possible, we would like to avoid that again. Of course, we have our greater and lesser palatine foramen. You can see that very well. We've got our greater and our lesser. I think the sagittal sections show it beautifully. We've got the greater palatine canal and foramen and the lesser palatine canal and foramen extending down. And of course, you have an incisive canal and foramen. Typically, this particular software, I point out the nose is up. But typically, as we come down through our axial sections, we'll evaluate that. I always want to look at it as far as size. If it's larger than 6 millimeters in size, it could mean there's a cystic process. Very easy with CBCT, we can look at our sagittal sections. And if it looks like we have a cystic process, or maybe even like a large hydrostatic grape put in this area, then we know we have an incisive canal cyst. But if not, if we have nice, straight, intact cortical borders, we know this is just an anatomical variant, nothing really to worry about. But of course, again, we do want to avoid putting the implant right within the incisive canal. And so here's a patient that came in with a complaint of numbness in the region of the upper lip. And of course, we can see exactly what happened. That implant was placed right within the incisive canal. Now, your incisive canal can have quite a bit of variations. Sometimes we see a trifurcation of the canal or a bifurcation of the canal. Again, any of our neurovascular canals can have variations. Zygomatic arch, we can see that very nicely here. Here's a beautiful picture of zygoma. And of course, we're going to have our frontal process, maxillary process, and our temporal process right here. See very well in those coronal and, of course, the axial sections. As we scroll forward, this is going to join with the maxilla with a little area. It's kind of a buttress, which we call the malar process. That gives us that J-shaped radiopacity that we see in all of those posterior maxillary PAs or on our conventional panoramic images. Next, we're going to move on to our sphenoid bone. I think for completion of anatomy, and because it's the most beautiful bone in the body, we're going to go ahead and talk about this real quickly. I think it's just such an intricate and beautiful butterfly-shaped bone. Of course, we have our foramen rotundum, foramen ovale, foramen spinosum. We've got our medial and lateral pterygoid plates, little optic canal. So maybe this is bringing back some lovely thoughts about your anatomy days in dentistry. But the greatest part about radiology, of course, is all of this anatomy does not smell. So much more fun. All right, so of course, if we're looking at our sphenoid bone, we've got our medial and our lateral pterygoid plates. Looking at it in our axial sections here, we've got our medial and our lateral pterygoid plates. They're just posterior to those maxillary sinuses. And of course, hanging off of that medial pterygoid plate, we have a nice little shepherd's hook known as the hamulus. So that's a fun little one to remember from those anatomy days. We also have the pterygomaxillary fissure, and we can see right here that nice little pterygomaxillary fissure. It opens up between, of course, our maxillary sinus and the pterygoid plates. This edge right here is the fissure, the pterygopalatine fossa, of course, being the inner part of that. I always do check from side to side, make sure that those cortical borders are nice and intact. We do see some pathologies that like to live in this particular area. Moving on to the temporal bone. This is a beautiful bone. It's not quite as exciting as the sphenoid bone, but it's still nice. We do have, of course, with the zygomatic process, we can have a styloid process, and we have the mastoid process where we have the mastoid air cells. And I talked a little bit about the fact that sinuses tend to not be symmetrical. They like to be asymmetrical. And our mastoid air cells follow that same rule in that they typically are not symmetrical. Now, we can see pneumatization of our mastoid air cells anywhere throughout the temporal bone. It's not uncommon to see them within the zygomatic process as well. So again, they can pneumatize anywhere throughout that temporal bone. So let's first talk a little bit about our styloid process when we are reviewing our scans. One of the things you'll notice, here's the airway space. This patient, the nose is down. Posterior and lateral to the airway space, we have a calcification. Now, it's the exact same way that we talk about a calcified carotid atheroma. We say it's posterior and lateral to the airway space. So how do I know if I'm looking at the styloid process versus a calcified carotid atheroma? Well, it's all in location, location, location. So our styloid process is going to be very high up in the neck, approximately at the C1, C2 level. When we're talking about a calcified carotid atheroma, it'll be at the C3, C4 level. So knowing what level you're at is very important. We do have stylohyoid ligaments as well, and those can ossify. So this is ossification of the stylohyoid ligament. And that does look pretty extreme. It almost looks like we have joint spaces. Actually, this is a fairly common finding. We find it in about 4% of the population. I know in dental school, we were taught that if you see this, it might be associated with Eagle syndrome. And yes, that is true. But of the 4% of the population that have ossified stylohyoid ligaments, only maybe 4 to 10% of them actually have Eagle syndrome. So you don't have Eagle syndrome unless you have symptoms. So in an asymptomatic patient, this is completely normal. In a patient that reports issues such as fainting if they turn their neck, or pain if they turn their neck, they're talking about an actual true anatomical impingement. Because it's such a common appearance to find the ossified stylohyoid ligaments, we typically will look at the health history to see if there's any symptoms before we try to put that together for Mrs. Jones. Because if you tell her that this could be associated with Eagle syndrome, of course, she's going to Google that and she's going to be sure that she has it. So, all right, we talked about the mastoid air cells, and they can pneumatize anywhere throughout the temporal bone. This particular software, the nose is up. And so this is, of course, our temporal bone region. And we can see what looks like these little, maybe multilocular hypodensities or radiolucencies. You'll notice you see them within the petrous portion of the temporal bone on one side, but you don't see them on the other. Same thing in our coronal sections. You see it on one side and not the other. And this is our mastoid air cells. In fact, this is the mastoid air cell region. They've just pneumatized anteriorly. They actually look very similar to the mastoid air cells. They're very well defined. They're corticated. They look like air cells. So we know that's what they are. Variation of normal, and we don't need to worry about them. Okay, then we have our articular eminence. Of course, you can see that very nicely as we come down. And our glenoid fossa region. So if you're in the temporomandibular joints, definitely I would recommend looking at the temporomandibular joints if you'll be placing implants. We want to look at that entire patient ahead of time and be able to rule out any issues before we go ahead and restore the dentition. We don't want anyone coming back and saying, oh, I didn't have TMD until you worked on me, which sadly does happen. But anyway, what we want to notice with this is we have nice, thin, intact cortical borders. And that lets us know we have a very healthy temporomandibular joint. Remember, we saw earlier with the sinuses that you get thickening and sclerosis when you have a chronic inflammatory process. So that's what we kind of want to make sure we don't have in the temporomandibular joint region. So here we have a nice, healthy temporomandibular joint region, nice, thin cortical borders within the glenoid fossa region. All right, we're going to move into the mandibular and cervical anatomy. We're going to pick up right where we were before, and we have our condyles. So you can see again, we have this nice, smooth, intact cortical borders. Again, letting us know we have a healthy temporomandibular joint. Now, it's important to realize these cortical borders are not fully ossified until an individual is between the ages of 21 to 22 years of age. So if you have imaged an 18-year-old and you don't see those cortical borders, it does not mean that they're not there. It just means that the cortical borders are not fully ossified and we can't see those cortical borders. So it's kind of something important to keep into mind. Right, the coronoid process, you can see that right there. That's the attachment site for the temporalis muscle. And of course, as we're going down through, we want to evaluate our mandibular ramus. This is the ascending ramus region. One of the things we do see a lot in the ascending ramus region is beam hardening artifacts. You'll notice it looks like there's kind of a dark line that extends through here. You can actually see this beam hardening artifacts and streaking coming off of all of these metallic restorations. They extend through that ascending ramus, and that correlates to the line we see right here. So a very common area for that, but by and large, it should be symmetrical. We should always evaluate those cortical borders. We really can't differentiate soft tissues with our CBCTs very well. So we have to be really good at looking at those cortical borders. We want to make sure they're smooth and intact, because if they're not, it could tell us that we have a pathological entity. So mandibular gland fossa region, we were used to looking at that on pans. We have a nice little dark area here. Very easy to see it with our CBCTs and be able to avoid placing an implant through that area. Of course, it makes it very easy to see salivary stones and know exactly what they are based on the location. We also have our mandibular foramen. This is the entry point for the mandibular canal. Entry point for the inferior alveolar nerves and vessels as they come through. And again, notice in that ascending ramus region, we have these beam hardening artifacts, all these little zebra stripes. You can see it very well streaking from the metallic restorations. And so definitely can see what's happening in this area. We don't want to confuse that with pathology. All right, our mandibular canal, we always want to evaluate that. Our mandibular canal can pretty much do what it wants. Again, it doesn't always read the textbook. We want to make sure that we have some nice intact cortical borders. And of course, we want to make sure that we avoid placing an implant within it. Now, we know about 5% of the population has osteoporotic changes, making it really difficult for us to see those cortical borders. In instances like that, you can definitely work with a specialist, such as an oral maxillofacial radiologist. Many times we can slice and dice things to try to figure out where that canal is and help you map that. Mental foramen, of course, seems fairly self-explanatory. Now, there is a variation with the mental foramen as well, because we can have bifurcations and trifurcations of our foramen as well. So we'll go ahead and look at some of those images. And of course, as we're extending through, we want to make sure that our cortical borders are intact, as I said. Always looking at the inferior cortical border of the mandible. Again, looking for symmetry. They should be fairly symmetrical. And wanting to make sure we don't have any sort of pathology going on. Of course, we do have genial tubercles in our lingual foramen. Right at the midline, here's our little lingual foramen. And again, he looks just like any neurovascular canal that we might have. Kind of that linear radiolucency or linear hypodensity when you're talking about it with a CBCT, and nicely corticated borders. Now we can see a variation with that. We can have one canal, we can have multiple canals. Again, this is all normal. Here you have a small little accessory canal as well. So we can see a lot of neurovascular canals in both the maxilla and mandible, and it'd be optimal to try to avoid that. All right, so that is a brief review of our anatomy. One of the things we want to put together as we're going through and we're evaluating this case for implant treatment planning is documentation. If you don't document it, then it never happened, right? So we talked about reviewing the entire CBCT. We want to document that we reviewed the entire CBCT. You can talk about your implant analysis, and you might want to break things down, maxilla, mandible, airways, sinuses, TMJ. This is really nice. It's a nice, handy little template. You can add it into any of your electronic charts. And then, of course, as you go down through the CBCT, your assistant can be documenting in each of these areas what you see. It doesn't take very long to review the entire CBCT. So it's pretty quick, especially if you have someone helping you document. But definitely want to document that we looked at it for our medical legal documentation. All right, when we're talking about applications for CBCT, there's a host of different things we can use it for. But implant imaging and treatment planning is the #1 reason that this technology was brought into dentistry. That's what we're going to talk about for the rest of the evening. But just so you know, you can also see developmental abnormalities, third molar and canal relationships, periapical and periodontal findings. It's great, of course, for temporomandibular joint imaging, trauma, any of our pathological findings, airway and sleep apnea applications, as well as orthodontic applications. But for today, we're pretty much going to talk about implants. All right, a general rule of thumb that we do see is that 2D will consistently underestimate the bone loss as well as overestimate the bone gain. And we see that time and time again. So we have many examples. But again, the number one reason for CBCT coming into dentistry was really that implant site assessment. Excuse me. All right, so when we're talking about assessing the anatomical features, one of the things that we do need to discuss real quick is jaw shape and bone quality. And I'm sure you've heard about it time and time again, but let me just go ahead and review that with you. Resorption of the mandible will be upwards and inwards with the maxilla will be upwards and inwards with the maxilla becoming much smaller over time with our alveolar atrophy. Very, very common to see that. Mandibular resorption will be down and out, and what we tend to see is that with our alveolar atrophy, it looks like our mandible becomes wider over time. And so very, very common again. Our bone qualities, yes, we can see bone quality with our CBCT. Now, sometimes our CBCT units will have something called HU for Hounsfield units. Really, because of the physics with CBCT, we do not have true density with our CBCTs. And that's really looking at gray values, where with medical CT, we do have true density. And so we can use those Hounsfield units to look at bone over time, bone gain, bone loss, that sort of thing. With our CBCTs, it's important to realize that we really haven't gone beyond the visual inspection. And that has to do, again, with the inherent physics with the CBCT having an extensive amount of scattered photons that hit the receptor. And again, we can see that anytime we're trying to look at soft tissues, we can't differentiate soft tissues. In fact, if you were to use that Hounsfield unit button and put it on any of the soft tissues, you'll notice that the variation in the numbers vary quite widely. In fact, you can play with that, see what you find. Air should be minus 1,000 if you have true Hounsfield units. You'll notice if you're playing in the air with a CBCT, many times it's a positive number. So it doesn't work the same as it does with medical CT, but we can still visualize things very well. And of course, we've got our type 1 bone, which is our dense cortical bone, similar to oak. I think they make it similar to certain types of wood. Type 2 would be similar to pine with a thick cortical border, and then we've got our dense trabecular bone. Type 3, we have our balsa wood. You've got, a thinner cortical border, but you still have a cortical border. And you do still have some nice trabecular bone. Type 4, of course, is basically styrofoam. Very thin cortical borders and, enlarged marrow spaces, very poor quality trabecular bone. And we can see that with our CBCTs. Even without having those numbers to tell us, it's very easy for us to be able to visualize it. So here we can see a granular bone pattern within that trabecular bone. That's letting us know that we've got a poor quality bone. We've got very thin cortical borders here. You can also see pitting, generalized pitting within those cortical borders. Again, very thin cortical borders there. So that lets us know that we do have osteoporotic changes with those patients, and we should expect that they're going to have poor quality bone if we're wishing to place an implant. We can also see pathologies as well. In this particular case, it was sent to us, and the question was, why does the bone look so funny? We can see these multiple mixed density entities all along the mandible as well as in the maxilla. This patient has florid osseous dysplasia. The bone, we have a metabolic changeover between normal bone to more of a fibrous component that then starts to kind of ossify. A lot of research about whether we can place implants into this type of bone. I would say actually the results are mixed. If you place the implant within one of those lesions, it's not going to osteointegrate, and so it's going to be an issue. These patients are at increased risk for osteomyelitis. So as a radiologist, we would say they are not candidates for implant placement, but this particular dentist had, a radiologist look at it. Then there was a second opinion. I would give my caveat, they were not an oral maxillofacial radiologist. So if you do have a question about something in the mouth, you probably want to send that to an oral maxillofacial radiologist because it is our area of interest. But unfortunately, on the bad advice that the individual got, they went ahead and placed these implants. By the time we got it, the implants are loose. The question, what's going on? And we can see clearly we've got the implants placed within our florid osseous dysplasia. Okay. When we are looking at the bone, we want to be able to determine the available bone height, remembering that the superior aspect of that bone usually is too thin to be usable. So it's not really part of the sufficient bone width. So we want to be able to go through and determine what is our level of sufficient bone width for a patient. And then we want to figure out where our mandibular canal is and leave at least a 1 to 2 millimeter buffer in between. So definitely take that into account. The ideal image should be able to provide inclination of the alveolar process, any of the location of anatomical structures, allow for evaluation of density, as I talked about, allow for the clinician to identify the area clinically, and be accessible at a reasonable cost. So these are what the ideal image should be. From that image, we can see exactly what type of fixture we might want, the length, the diameter, the axis of orientation. Most CBCTs will come with software that has implant treatment planning with it. They'll have different implants. So whatever you're accustomed to using, it's most likely already within the catalog of that implant treatment software. So easy to place it in, kind of test out that implant ahead of time, test out the inclination so that you're going to have optimal occlusion and that sort of thing. So it just makes it so easy nowadays. So here's a couple of examples, kind of 2D versus 3D. And again, these are always just fun examples to show. In this particular case, based on the 2D image, the implant looks like it's been placed nicely. We know that the majority of these will osseointegrate. But when we look at things in 3D, sometimes the truth is different than what our 2D was telling us. So here we can see the apex is not in bone. We have no buccal bone here. Very minimal bone is actually holding that implant in place. Here's another one. Implant looks great, well positioned within the 2D image. In fact, it looks like we can restore it quite nicely. But when we get into the 3D, where is it actually located? So we can see that it is lingual to the cortical bone. And in fact, there's very minimal bone that's actually holding onto that implant. This implant's actually not restorable. So it's kind of a bad day. All right, so what's the recommendation for implant treatment planning? As far as the American Academy of Oral Maxillofacial Radiology goes, in conjunction with dental implantology, it recommends that cross-sectional imaging be used for the assessment of all dental implant sites, and that CBCT is the imaging method of choice for gaining this information. So here's another example. Now this isn't, we have a wide judgment zone. We know, we've been there. We know people have bad days. This was an excellent clinician, and he's placed thousands of implants throughout his lifetime. But you can see that he made a mistake in measuring on an angled posterior maxillary PA. He then came running down to radiology with the comment, "I lost the implant." And guess what? We found it with the carrier mount and everything. So in fact, if you look closely at that implant, it looks just as shocked as we do that it's sitting there. But this is a very bad day. This is I'd say a bad day for the clinician as well as the patient. So we can try to avoid that with our 3D imaging. This was a patient that had a history of a failed implant. They were new to this particular office. They took the CBCT, and guess what? We found it. So the nose is up. It is located anteromedial to the sinus. It has actually osseointegrated along the lateral cortical border of the nasal fossa. And so it will live out its life there. See, the majority of them do osseointegrate wherever they're at. This particular one, look where that implant is in relationship to the mandibular canal. Somebody got a little bit lucky, didn't they? In fact, look at the canal on the other side. Look at this. We went ahead and traced that. And you can see the bifurcations or trifurcations going on. So definitely we want to always map out the mandibular canal before placing the implants, because the canal, again, can do kind of whatever it wants to. Here we have a superior accessory canal coming off. We've got these little bifurcations and trifurcations, little bifurcation over here. We've got an anterior loop. This was a bad day. Look where that implant is placed within the superior aspect of the mandibular canal. So patient's going to have neurosensory deficits. It is just not a good day. This was a case I did just a couple of weeks ago. And look at this canal. You actually have two separate canals on each side. There's anastomosis between the canals. We have anterior loops. Again, the canal can do whatever it wants. Many times it hasn't read our textbook. Definitely would want to know this is going on before trying to place implants. Again, with our mental foramen, we can have one foramen or two or three. So we definitely want to make sure that we realize what's going on. Sometimes we'll see a canal extending back along the buccal aspect of the cortical bone. So we do see some wild things. If patients have had orthognathic surgery, definitely very important to be able to map that canal. Sometimes they will actually remove the nerve from the mandible, and we can see that neurovascular canal as it kind of moves around from the buccal and then re-enters the mandible. So it just really can do a lot of different things depending on the history of the patient. Now, this is a great example of post-grafting with our CBCT. We can see that based on our 2D, our sinus lift and bone graft looks pretty good. Luckily, they did go ahead and take a CBCT ahead of time before implant placement. And what do we find? Well, we have a large fibrous defect here. We've got a mucosal thickening that is iatrogenic in origin. But where did all of our bone graft material go? The patient actually swallowed it. So that was a very expensive swallow. Definitely would want to know this ahead of time. Here's another case where they had performed a sinus lift and bone graft, and based on the 2D, doesn't look too bad. But coming in on the 3D, what has happened here? Well, obviously, it broke through our membrane, or something happened with the membrane. It extended into all of the soft tissue, also extended into the sinuses. We have not integrated at all. That bone graft material is not integrated at all. We also have a mucosal thickening that is iatrogenic in origin. Here's another case. We have a site preservation bone graft going on. We get into it expecting that it's, integrated well enough for us to place the implant. Again, we have a large bony defect, mucosal thickening that is iatrogenic in origin. We've got some of our bone graft material is floating within that mucosal thickening. And as we go through, what's happening to the sinus here? Well, our ostium was blocked, and so the sinus started to expand. And that's that mucocele where the sinus is acting like a pathological cavity in and of itself. We have got displacement and erosion of cortical borders. Obviously, this has to be a team approach to fix this for the patient, along with ENT. So again, really want to have a good team on your hands. And but this is a very bad day for everybody. But these things do happen, so we want to plan accordingly. This is another one. Based on the 2D, we can see our sinus augmentation. Multiple implants been placed, but this implant looks pretty good. It looks like it's actually within the bone. Looks like it here as well. But we get into our actual 3D volume, and you can see that this is the bone graft material. The implant is not in the bone graft material. It's in the sinus. We have a mucosal thickening again that's iatrogenic in origin. How much bone is actually holding that implant in place? Very minimal amount. So that'll affect the longevity of that implant. I would say that one of the best reasons for CBCT is surgical guides. So definitely we can make our surgical guides based off of the CBCT. They are extremely accurate. We've done a lot of research with it. We're talking about research with dental students placing implants on models with their surgical guides, and we found that their degree of variability in placing the implant correctly when a surgical guide is used is about 0.03 millimeters variability, or 0.04, depending on the pilot studies that we've used. So very, very good accuracy and repeatability. And that was with dental students. So obviously with a clinician, we know that it's going to be a lot higher. So very, very, just amazing. I don't think I would place an implant, especially if you're first starting without a surgical guide. It's going to decrease the amount of time it takes you to place that implant. And it's going to come with a nice recipe to tell you, what drills to use. It makes it a little bit more foolproof for you, and it kind of takes off some of that stress and anxiety. Now, of course, those can also be, the surgical guides can be 3D printed. Very easy if you have a 3D printer in your office, or you can send them off to a company. Probably in the beginning, I'd probably send them off to a company. It's going to make it much easier for you, and they'll look through your scan and tell you if there's motion. They're not going to typically tell you if there's pathology, but they'll tell you if there's motion and if you need to retake it. So here's a case when a surgical guide was used, and this was this was an oral surgery case. You can see that the lateral incisor was congenitally missing, very minimal room. Using the surgical guide, they were able to place that fairly perfectly right in between. So definitely a case you'd want a surgical guide for. Because we know that just because there's a huge area to place that implant, we can't always place it the way that we have envisioned. Many times it doesn't seat exactly the way we want. So here's a couple of cases. Implant treatment planning maybe didn't go quite right. We got all on 4, and oops, this guy failed to seat. So surgical guide might have helped us with that. Here's another one that the implant is actually in the sinus. So, some implant treatment planning might have been helpful with that. Very minimal amount of bone that's actually holding that implant in place. And we can see that there's not a mucosal thickening in the maxillary sinus, so we don't have inflammation going on with the location of that implant, but the longevity of that implant will be decreased. These are some that I just got recently. Again, we get quite a number of these, and I would just say that these may have benefited from some implant treatment planning. Obviously, if the implant is placed this way, this is not going to go well. It's going to be very hard to restore. It's not really a restorable implant. Here's another one. Patient with severe periodontal disease, and we made sure we seated that implant, and it's seated right into the mandibular canal. So that is a really bad day, and obviously, clearly, this is not something that's restorable. All right, so like I talked about, many of your CBCTs will come with implant treatment planning software, but there's other software out there on the market. There's a ton of software. This is Implant. Many of these softwares, you're going to see a panoramic reconstruction. You'll get your 3D skull view, and then you're going to have some other selected sections. This one has an axial view. This one, of course, we have our correlated cross-sectional views. So where is this? Well, this will align with, putting together your panoramic reconstruction. And then your cross sections will kind of move along there. So we can see our lines right here, and you can move this along, and it's going to give you those cross sections up in this area. But again, you're just going to be moving in the software, you're just going to be moving along that panoramic ridge. Important to remember that because we still need to look at the entire CBCT. Sometimes we just want to look at that panoramic view. And if we do that, we're really only looking through the mandible. We're not looking at the entire CBCT. Here's Blue Sky Bio. This particular one, again, so you'll go ahead and draw your focal trough for your panoramic reconstruction. You're going to have lines. So these little lines right here, these are cross sections, and they're going to correlate with these cross sections up here. So you always know where you're at. But they're going to make it very easy for you to do implant treatment planning. Go ahead and send out for a surgical guide and that sort of thing. You can go ahead and, kind of test exactly where you want that implant to go. Obviously, we can use our optical impressions, and we can combine that with our CBCTs, and we can have a nice entire plan, restoratively driven plan for that implant placement, which I think is incredibly important. In the beginning, we were just placing these things and we wanted to see if they'd osseointegrate. Now we want to make sure that they're restorable. So of course, you can use your CEREC data, combine it with your CBCT, and using, in this particular case, CCAT function, you can go ahead and look at your patient dynamic occlusal data, as well as your digital occlusal adjustments. Combining all of it, it's just amazing what we can do with CAD/CAM, of course. Combining, of course, your CEREC with your CBCT. Very, very easy to be able to do that. And this is what it would look like. So plan your restoration and bring it right in. And of course, we can completely create our entire virtual patient that is working in function. So just phenomenal what we can do with all of this technology. Just real briefly, I know we're getting to be at time here, but kind of go over, what is our process with this. You begin with your CBCT, then bring in your CAD/CAM data. You can add your implant of your choice, add any of your surgical guides or abutments using your software, and again, send that off for a surgical guide. Here is a treatment planning using Sidexis. So this is one of the Sirona units. Again, you're going to obtain your CBCT. Again, you can use your virtual planning implant system of choice because there's a whole host within the catalog. We can validate it, and you can send that off for a surgical guide. Same thing with Anatomage. So this is an example of implant treatment planning with Anatomage. So obtain your CBCT. They're also going to have a catalog of all of your different implants. And then again, you'll validate and your surgical guide, sending that off. And of course, there is GPS guided implant navigation. So if you want to go even beyond, we can use your CBCT and work with an implant guided navigation system. So really, today's digital dentistry is just the tip of the iceberg. And there's so many places that you can go. So thank you. I appreciate your time. Apologize for going over just about 5 minutes. But are there any questions?
There are. Heidi, thank you so much. And I do want to say before anybody leaves, you do have a chance to see Heidi in person. She's going to be at DS World, September 23rd to the 25th. So if anybody's interested in complimentary admission, and you don't have a CBCT or you don't have the CEREC system, and you're interested in meeting Heidi in person, reach out to your Henry Schein representative. Look forward to seeing you there. We do have some great questions. Heidi, thank you for the wonderful presentation. Dennis has been great at asking some great questions. So we are over, but I want to stay tuned like we always do to get all the information in. Dennis asks, can you see the posterior lateral nasal artery canal on CBCT?
Oh, that's a good question. The posterior lateral nasal artery canal. Um, you probably can if it is big enough. Any of our neurovascular canals, you can see if they're big enough. Very, very common. So I would say yes, you probably can see that.
Okay. And again from Dennis, the submental artery may be found directly on the medial fossa of the mandible with age and edentulous. CBCT is extremely important to prevent a lingual perforation and laceration of the submental artery. Does the submandibular gland cause the fossa to deepen?
Does the submandibular gland cause the fossa to
deepen?
So that's a great question. Now we can see Staphny bone defects. I think is where this question was going. We can see Staphny bone defects, and that's a herniation of that glandular tissue as well as fatty tissue within the mandible. We don't exactly know, the etiology of that is unknown, so we don't exactly know what creates that. There's a bunch of different theories behind that. So, originally Staphny thought this was a congenital thing, but then he realized he wasn't visualizing it in anybody younger than 11. So it's actually more of a developmental issue. And so it's something that develops over time in certain individuals, and it can happen anywhere you have glandular tissue. So it's not just in the submandibular gland region, but it doesn't happen in everyone. There's just a certain small percentage of the population that we might see that in. In that case, we're going to see very well-defined cortical borders. It's a slow-growing entity. It will remodel the lingual cortical border of the mandible. And, with any slow-growing entity, it has time to remodel. The appearance of it with very thickly corticated borders is pathognomonic for the entity. In the beginning, they'd send them off for MRI, being kind of worried about what's there. But because the visualization, even in our osseous structures, is pathognomonic for it, we no longer do that. So,
great, thank you. If the sella turcica is greater than 9 millimeters, does that indicate acromegaly?
Not necessarily. So your sella turcica, the size of the sella turcica is typically about the size of a dime. So, what is the size of a dime? Like 18 millimeters or so. I guess it depends on the individual, but when we're looking through, if we do see a sella turcica that's larger than the size of a dime and has a hydrostatic appearance, we will send that patient on for additional imaging. Again, we can't see the soft tissues. We're looking for some type of pituitary pathology in that area. And we're going to really need to send them on for an MRI to be able to look at the soft tissues and see what's truly going on. Many times, if they actually do have a soft tissue tumor within the pituitary gland region, you're going to see that the sella turcica is expansile. Those cortical borders are expanding down into that sphenoid sinus. They are going to, like any pathology, it's going to kind of follow the path of least resistance, and it can easily expand into that sphenoid sinus. So if you're looking through, you notice that it is larger than the size of a dime. You'll notice, hydrostatic appearance with expansile borders that look like they're impinging on other anatomical structures. That's, of course, we want to send that patient on for additional imaging.
Okay, great. What's the best age for upper anterior implants in a teenager? Congenital missing maxillary lateral teeth.
That's a great question. Definitely they need to be of skeletal maturation. I think there's a lot of different research talking about when might be an optimal age for that. So definitely upon skeletal maturation. So maybe late teenager, okay, is what I would say.
Great. And already we've gotten lots of compliments on the program and to do more of these. So I'm sure I'll see you again. But the final question, can a displaced implant into the antrum relocate into a deeper location or a different anatomical location?
So if the implant has already been placed into the sinus, can it relocate? So I assume we're talking about an implant that's floating within the sinus.
It sounds like, and I think it came at the same time you showed the one that was displaced into the sinus.
Yeah, certainly it can travel. Just like the one I showed you that was osseointegrated along the lateral cortical border of the nasal fossa. Obviously, that did travel, and they will. We do have some amazing anatomy within our sinuses. We have all of the little cilia that help to kind of, move and facilitate all the mucosal thickening to drain properly through the ostium. And it can do the same thing with our little implant. It can move it along with that mucosal thickening. So yeah, it can move.
Okay, one more. Are there any special considerations for patients that have a missing lateral upper with history of cleft palate and lip?
Well, certainly I would want to review the CBCT. We know that they don't always, well, they usually have a very atrophic alveolar ridge. Many times they don't have any bone in that area. We want to make sure we're not just placing it within the soft tissues of that cleft or whatever else that they might have. So I think that with all of that, we really look at the CBCT and evaluate what bone we actually truly have and whether we need to have a bone graft in that region.
Great. Heidi, thank you again. Great to see you always. And if anybody attending is interested in future Henry Schein webinars, please visit henryscheindental.com/webinars for upcoming schedule. And everybody attending tonight or registered for tonight will get an email with a recording of this as well. So thank you all for joining us, and we look forward to seeing you on future webinars. Heidi, good night.
Thank you. Have a great evening.
Good night, everyone.